Dr. Nathalie Fiset. I'm semi-retired, but in my 25-year medical practice, I've delivered 3,700 babies, many with using my program Hypno-Baby. And I want to share with you part of the course just to give you a little information that's included in the course, just a little peek if you want. So without further ado, jump on in. So in the and after a medical study, you always have to have the discussion part of the study. So we stated, and we is me again, one woman show. So the cesarean section rate has been increasing during the last 50 years. The rate was 5% in the 1940s and 1950s. And the reason for that is that it was very dangerous to do surgeries. So they did not have like cesarean unless you were like the king or the queen, or not the king but the queen, or somebody really special that could afford like the best doctors and all that stuff. So it was really rare that they would do a cesarean. It was 5%, and then it remained unchanged for 10 to 15 years. And then in the late 1970s, the rate rose to, it jumped, it did not rise, it jumped to 15%. It remained unchanged for the next 10 years. And then in the last decade, there was a dramatic increase in the C-section rate worldwide, which now exceeds 30%, like we were saying, 33%. Why is that? Why? Well, first, many doctors are afraid to be sued, so they'd rather say, well, I took steps, I did a C-section, so they want to cover themselves. So that's why you're going to be prepared to ask the right questions. Is baby safe? Is mother safe? Can we wait a bit? And also always like in a safe way. Okay, not put yourself in danger, or the baby in danger, just for for the sake of having a vaginal birth. That would be foolish, of course. But so many times, and I had a gynecologist that I was getting along very well with her, but every time she decided on this C-section for my patient, saying, the heart is not reassuring. And sure enough, when we did the C-section, baby has an Apgar 11 screaming in your ears and almost slapping the the staff in the OR. I'm just kidding. Apgar is maximum is 10, but still it shows you. And then the gynecologist would say, oh, it recuperated. Like, okay, it was not in jeopardy to begin with. That's the big secret here. It's not, should not be a secret. That's the truth here. Okay, so often. And the thing that made skyrocket the cesarean rate is because we started listening to the baby's heart. And first thing, even if we monitor your heart, and anybody, and a healthy adult, for 24 hours, you get all kinds of extra beats and all kinds of anomaly. That's normal, okay? We're not like clocks, we're humans. So especially babies, they have immature hearts, so they do it even more. So perfectly normal that the heart will vary and up and down and do all kinds of, and it gives all kinds of false signals. That's why so many babies recuperate right after the cesarean, because they were not in jeopardy to begin with, okay? The more you listen, the more you're gonna hear and find stuff. So that's why, like, the monitor with the straps and the the fetal Doppler, um, do as least as possible, because as least as safe possible, because the more you listen, the more you're going to hear things. The other thing is, you have to realize that any human and pregnant woman, we have the aorta, the big artery, going down, and we have the inferior vena cava going up. That's our big vein. So that beats too. So often you can hear mommy's heartbeat, or even a combination. Like, the monitor is not that intelligent, so it might listen to one beat of the baby and one of the mom, and do like how should I say, a mix of the two, like an average of the two, and give you all kinds of weird number. It's also electronics, so electronics, radios break, so again you get all kinds of weird monitoring. And they did a study, and actually the recommendation nowadays is to do intermittent monitoring, meaning not listening to the baby all the time, because like I said, the more you listen, the more you hear stuff. And actually that increase in cesarean, and that's really important, going from 5% to 33%, the mortality rate did not improve on the baby and on the mom. And it actually, like, there's more problems for a mother, like not necessarily mortality but complications, because a cesarean is surgery. So just to tell you, all this did not uh, prevent, like, did not improve the baby's outcome, but we're kind of stuck with it, and nobody would in their right mind, like no healthcare provider would say, well, I'm not going to listen to baby, we're going to trust nature. That would be like lawsuit right there. So we're kind of stuck with that. But just to tell you, I went to a medical obstetrics medical conference at Harvard University, and I was like, okay, Harvard, this is going to be good. And then the first speaker starts and he goes, I got sued for this, you're going to get sued for this, my colleague got sued. So it was all about lawsuits and how to prevent it, and he was like, 100% you're going to get sued in your practice within the first 5 years if you do obstetrics. And I was like, oh my God. And I've never been sued in 25 years in all my 3,700 babies, never been sued. So and again, I'm in Canada, so it's a little different, but not that much. Just to tell you that sometimes the cesarean is also like because the doctor wants to protect himself, which is like human and pretty normal, and that's why getting back to what's recommended is intermittent monitoring. And it's actually monitoring, like, not even with the Doppler, it's with a fetoscope, which is like a stethoscope that the nurse puts on in her ears and listens to the baby's heart. Honestly, I had trouble with that because we tried to implement that in our hospital. And first, it takes a nurse that stays and listens to the baby's heart for 10-15 minutes. And it was more convenient to just put the bells and come back and look at the graphs. Okay, so again, it takes time, which we did not have much. And also, like, when I was with a nurse that made me repeat often because she was older and she had hearing problems, I'm like, is she hearing the baby's heart good or not? And I had to let her, like, fold my parachute and then jump out of the plane relying on her, and I was not comfortable with that. The third reason is that the younger nurses are not trained to do intermittent monitoring. They don't know, like, they have not done it enough. So it never took, really, but that's what's recommended. At least, and if you do your birthing plan, which we're going to discuss in other lessons, at least you can say don't put like continuous monitoring, because we don't want that. Intermittent monitoring, at least with the Doppler, so that at least you hear it and you get a graph. If they have someone who's trained with the fetoscope, that's the best way to listen to the baby's heart. But again, like I said, there's all kinds of beats, and it could be the mom's heart, and it's normal for a mom in labor, especially in very active labor, her heart can be 90, and then they're going, oh, well, the baby's like under 100, but it's actually the mother's heart that they're hearing. Or like I said, with the Doppler, it calculates an average of both heartbeats. So there's a lot to it, and there's a lot of unnecessary cesarean because of the baby's heart, baby crashing, baby's heart non-reassuring. And sure enough, most of these babies came out screaming, and they have a very good APGAR, and everything was fine. But because of the pressure that's put on gynecologists and obstetricians and family doctors and even midwives, they do intervention. That's the other message, is don't run to the hospital the second you have like half a contraction. I've never had a patient that the baby drop and without her feeling it. So you'll know when you're in active labor, okay? And when my patients are like, well, I'm doing the program and I'm afraid I'm going to miss the birth, and I'm like, let's talk after the baby's born. And every time I would say, did you miss it? And they go, no, I knew that, like, I was comfortable, but I knew my body was giving birth. So if you rush to the hospital, then well, first you get more intervention. Oh, let's break the water, let's pitocin, let's do this, let's do that, and then, oh, your cervix doesn't dilate. It's not right, it's not ready. And same thing, they listen to the baby's heart, and if you're at the hospital 24 hours, they listen for 24 hours. So then, of course, you're going to get like all kinds of anomalies which are temporary or not even there. So I'm not saying labor at home until like the baby's between your legs. I'm saying as long as you feel the baby moving between contractions and you're feeling fine, don't rush to the hospital, because then you get into more interventions and more baby monitoring, which is the #1 reason for the rise in C-sections. The other reason is that once you've had a C-section, often some hospital will say, oh yeah, we're very, and I'll talk a lot about this in the Vbac course, the side course where you're going to find the button. But they say, yeah, we're all for, Vbacs here. We're very, and then the second you step in the hospital, they find reasons. Oh, baby's not coming down, this and that, and then the heart rate, and sometimes you even see it, like you have red flags at the office, like your doctor's like, well, we'll do a C-section if this, we'll do a C-section for that. And you're like, they're not gonna allow, quote unquote, allow me to have my VBAC. Like it's not a fair chance here. Okay. The other reason for the increase in C-sections is that we started doing all the Friedman curves and saying like, active management of labor. What an awful term. Like your body is the only active manager of your labor. But if somebody has not dilated for 2 hours, you start the pitocin and all kinds of, they're all interventions, okay, honestly. But the Friedman curves is the dilation and compared to the hours. And often they say, well, you have not dilated 1 centimeter in the last hour. Let's do this, let's do that. And that is as foolish as saying for the Boston Marathon, everybody will will come at the finish line at the same time. Okay, take a second to realize this is ridiculous. The first one will finish in 3 hours because, his legs are made for running and he's been training and everything. And it's not his first marathon. The last one might finish in 24 hours and some will not even finish. But for birth, we all have to finish. We all have to have the baby in the end. But, just to tell you that not everybody is at the same pace, and that is ridiculous to put that kind of barriers. If you saw my Friedman curves, like my dilation per hour, it takes 2 sheets that would be like scotch taped together because it takes me 24 hours. I'm yay big, I'm 5 feet tall, I had 8 pound 10 ounces baby. They had to take their time, and my body had to take the time that it needed, and I birthed. So just again, make that clear with your healthcare providers that you're not going to be on the clock. Okay, your body's not going to be on the clock, and that's going to be you have to put that in your birthing plan. If you're planning a VBAC, vaginal birth after cesarean, again, no induction, because then and it increases the risk of having like we'll discuss all this in the side course, but the risk of rupture, because you're pushing the contractions, you're making them stronger, and many women who had pitocin say the contractions are really intense. And why not trust nature? Like labor, the contractions start and they increase gradually, and that's why it's we are so proponent of natural birth with the Hypno-Baby, because you have time to adapt. And then the stronger the contraction, the stronger the hypnosis, the stronger the comfort. But you have time to adapt. You're not like hitting a brick wall to begin with, like the pitocin and up, and then poof, it starts all of a sudden. But I'm sidetracking here. But the main thing is intermittent monitoring will help you reduce your risk of cesarean. Again, you have to discuss all this in the office with your healthcare provider before getting in labor and then saying, well, the protocol here at the hospital is this and that. And same thing if you're preparing for a VBAC, yeah, well, you have to do this and this, and make sure you understand like the rules of the game, if I can say, how they play the game. So the funny thing is that since 1985, you get that 1985, I was not even in medical practice then, and many of you were not even born. The international healthcare community, and that's the World Health Organization, has considered the ideal rate for cesarean sections to be between 10 and 15%. That's kind of laughable right there. And it has been increasing ever since then. And if you look at my rocket, it's been increasing like crazy. And they're still saying, and I read the article that was written in 1985, and they're like, we're pretty optimistic we're going to reach that number very soon. And it's been going up, up, up since then. So yeah, there's something not right.